Thank you so much, Chairman Paul, for introducing me. And I would like to thank to committee and also to Professor Akiyama and Professor Riba, who asked me to come to this meeting. It's a wonderful meeting. I can share ideas and maybe get some ideas too from you. I come from Indonesia, and today I want to talk about the challenge of consultation liaison psychiatric service in Indonesia and how can we improve it. So we know that the prevalence of psychiatric disorder in general medical inpatient has been estimated to between 20 to 40%, and in special populations like geriatric patients, we know that the diagnosis with dementia, delirium, depressions is very common in hospitalized patients. But unfortunately, studies show that psychiatric disorders often unrecognized by non-mental health physicians. This is the report from International Medicine report a long time ago, that there is a fragmentation of responsibility in general hospital, so poor coordinations of care and also the poor communications of care among providers. And the result it will be leads to excess mortality and increased cost of medical care. So I think we are known that we need the integrated care at all levels of mental health. Professor Riba talked about the primary health psychiatry, and most of the psychiatrists now working in the hospital, in general hospital, as a CL-Psychiatrist also, not only a general psychiatry for the mental health patients. So the better communications among caregivers and patients is needed to improve clinical outcomes and prevent medical errors and also to reduce costs. So this is the generic model of integrated care. We know that the early identifications of disorder, proactives not only become to referral, not only waiting for the referrals, and interdisciplinary communications. So we know that the team and the patients has to be collaborations and communications needed to the interdisciplinary collaborative care. So based on the background, I have thought in mind that how about making a survey to healthcare provider in general hospitals. And in February 2013, I have 75 respondents, voluntary participations, whether we asked them about the needs of psychiatric treatment and collaborations in general hospital. The respondent characteristic is most of them are GPs and general practitioners, and also there are specialists, internship doctors, and also the nurse. When we ask them about the number of beds in hospital, they have about most of the respondents say there are only about 100 until 300 beds in their hospital. And when we ask them, was there any psychiatrists in the hospitals, only about 38 respondents say yes, and 22 respondents say there's no psychiatrist, and 12 respondents say there is a visiting psychiatrist to the hospitals once a month. And about 52 respondents say that the psychiatric problem in medical patients are often seen in medical setting. When we ask further about how often in a month there is a psychiatric cases, more than 50% say that 1 to 5 cases in a month, and there are only about 19 respondents say that about 6 to 10 cases, and there are only about 5 respondents say that there is 30 cases in a month. So when we ask them again, you are physicians in charge in the hospital and in charge with the patient with the medical ill, and based on your knowledge, based on your diagnosis, what are the prevalence of psychiatric disorder that you have in the general hospital that you care for the patients. And surprisingly, that there is a depression, anxiety disorder, and insomnia. I have read one of the studies said that the depression is one of the most prevalent psychiatric disorder in medically ill patients. And when we asked who is the physician in charge, less than 50% said they're psychiatrists, and however, GPs took care of 25% psychiatric case in their health institutions. Most of the respondents said the need of CLP team in general hospital, they need, because there are so many medical disorders and comorbid with mental disorders, but only 75 respondents said that there was no such team in their hospital. So what do I do in my hospital, and what kind of model of integrated care that most psychiatrists in Indonesia use in their daily practice? First, I would like to talk about my Indonesia. We have a population almost 250 million by 2013. We have 34 provinces are divided to 403 regions and 98 cities. The free view of Indonesian conditions by 2014, Indonesia has about 1,700 general hospitals and 9,000 community primary health clinics. There are only about 840 psychiatrists produced by 8 Department of Psychiatry at university, because in Indonesia we are university-based training residency, not hospital-based like in America. In Jakarta, in capital city of Indonesia, about 300 registered psychiatrists. So most of the psychiatrists are in Jakarta and in Java Islands, the most populated island in Indonesia. There are only about 38 state and local government mental hospital. About private hospital, especially mental hospital, only one in Jakarta and only one in my hometown, Tangerang, about 20 kilometers from Jakarta. So the fellowship training program in psychiatry, they are only child and adolescent psychotherapy and forensic psychiatry. We do not have formal fellowship training in CLP. So this is the models of consultation liaison psychiatry that Professor Riba said today, and this is also proposed by the FPM Residence Education Curriculum. So we are in here in Indonesia. We don't have mental health integrations or even proactive mental health involvement. So our CL-Psychiatry program or services based on a request, so it would be rather reactive. And the traditional models will be reactive and no primary patient responsibility. And we do not have any informal educations to the patients or to the consultee itself. And the non-integrated psychiatric consultation model, we know this is not address barriers to effective clinical or cost-effective care, because it has no collaborations, poor integrations, so there is no educational component itself. The ideal will be a CL psychiatric program. There is a screening for early detections of mental disorder. There's a prevention program. There's also a resource for the educations about mental disorders. So, what do I do to improve integrated care in my hospital? I have an educational meeting with general practitioners that work as assistant in patients unit about CLP and psychosomatic. I also held a periodic discussion with the intern, with other specialists in my hospital. The problem is it's very hard to gather them all. It's because they are very busy and because they are not interested in psychiatry also. And also to join CLPM organizations to get updates in this field. I met Professor Riba in the WPA meeting in Beijing, and I'm very honored to meet her, and she is supporting me very much. So this is also the Congress that I joined as an advisory international board will be in August 19 and 215 in Glasgow, Scotland. So I held update in psychosomatic medicine for general practitioners in my district every year since 2011. We talk about common disorder in mental problems related to the primary care service, because we want to know there are update in the psychiatric problem. So sometimes we talk about psychotherapy, sometimes we talk about insomnia. Last I talk about insomnia with my friends, the sleep medicine specialists also. So what do I do in my faculty? I and my students in faculty has a psychosomatic medicines interest group, a journal reading club for students. We talk about mental disorder and medical disorder because we have only 3 weeks in medical education program to talk about psychiatry, and it is very closed and it's very hard to talk about many mental disorders, especially with related to the medical disorder. So there's a journal reading club students, and I also make 2 books related to the mental disorder and medical disorder. This is a book about psychosomatic, and also this is a book about the Indonesians say "Don't call me crazy." This is "Don't call me crazy." So, and for the summary, there are many general hospitals in Indonesia that do not have psychiatrists in charge in the hospitals. Can you imagine there is only 840 psychiatrists for 250 million populations? Traditional model of consultation in daily practice, we still hard to gain stigma from other specialists. They only refer to us when they have a psychotic or aggressive, or just like Professor Nishimura said that there's only about how to transfer only for the rest of the life of the patients when they have a problem with psychiatric, even the psychiatric problems resulted from the medical disorder. Some of the psychiatrists improve CL-Psychiatrists by doing some educations to interns or GPs, but when I ask my friends that pay interest in CLP, they said it's very hard to talk with the, to the managers, to the specialists, especially to the CEO of the hospital, especially in private hospital. When we ask them to gather some CL team, they said it's cost too much. Yeah, so when they come in their mind when psychiatrists and specialists together in the team, there will be so much cost, and also related to the insurance company that do not cover. I have once experience when patients with pain disorder, I think it is back pains, and then it's diagnosis with hernia nucleus pulposus, and then it's consult to the psychiatrist, and the insurance company asks what is the purpose? What was the purpose to see psychiatrist? Is the patient crazy or something? And sometimes the patients also reluctant to see a psychiatrist. Even the consultant want to refer the patients for the psychiatric interview. I think I hope this talk will give an opinion from you all, and I want to get some ideas how to improve CL-Psychiatrist educations and also CL-Psychiatrist service in developing country like Indonesia. Thank you very much.